Our next speaker today is Dr. Samuel Asirvatham. He is from the Mayo Clinic in Rochester, Minnesota. He will speak to us on MRI-compatible pacemakers. Are they living up to their promise?
Well, thank you very much. So just in the next few minutes, maybe 15 to 20 minutes, going to review some important clinical aspects of MRI and cardiac devices. We'll just review the issue of electromagnetic interference, cardiac devices, what it takes to make a conditional device and what exactly that means, and what can we do with reasonable safety for patients with ICDs, left ventricular leads, or abandoned leads, and other cardiac devices along with a pacemaker or defibrillator when it seems that we need to do an MRI on that patient. So disclosures, I'll point out during the talk any specific device or concept that there may be a conflict. So if we start off, what are we scared about? What is it? What's the problem? General with EMI. So if someone has a device, and whether it's an MRI or something else, and we suspect that EMI, electromagnetic interference, can be an issue, what is it that concerns us? And really, the information on this or the guidelines for this go back a long time. The most concerning things are function that affects physiology. So inhibition of pacing or tracking that actually produces rapid pacing, and either of these give rise to presyncope, syncope, or dizziness. Now, the key to these, I think, are that the symptoms occurring at the time of the procedure should have either an excellent way that you can program the device to prevent it from happening altogether, or you should be able to stop the procedure. And this is what the challenge was for all the years before we thought or had conditional devices. You couldn't always prevent a resetting of the device. So even if it was programmed in a way that may be safe for that patient, if it reset the device, the electromagnetic interference, then it's kind of back to square one. And the second key issue is some aspects of the procedure you couldn't turn off or you couldn't stop. So once you were committed to starting the procedure, if there was going to be a major physiologically significant issue, you were stuck, and it would have to be some form of resuscitation of the patient. Now, all of these are pertinent for magnetic resonance imaging and when you have cardiac leads or cardiac devices in the patient. Asynchronous pacing, rapid pacing, as well as problems with the lead, especially heating at the electrode tip, can occur for a variety of reasons that we'll explore shortly. Give you an example of a recent case. Kind of complicated situation, and decision making was difficult beyond just the issue of getting an MRI. But patient had a prior history of cardiomyopathy, did have previously a left atrial appendage thrombus, and now developed issues that she wound up getting a dual chamber ICD. Goes to an X-ray right after implant, and at that point gets a facial droop and slurred speech. Just had a procedure, so TPA is kind of out of the question, I think. And what is it that's wrong with the patient, and how will you evaluate? So she gets a head CT done, and it's essentially normal. So what do? You say, well, the head CT is not good with an acute neurological event. Her symptoms were primarily motor, and I think that's significant because that would suggest it's just small vessel disease, maybe a little hypotension during the procedure? Or is this for sure something that we'll need to do about preventing further embolization? Or should you get an MRI to try and figure this out? Now, I think today it's getting more of an issue because there are options where you could try to prevent further embolization, perhaps without using anticoagulation at all. And especially if this becomes proven or standard, this could become an issue where you just don't have the fallback of saying like, well, let's just give some anticoagulation. There's nothing else that we can do anyway. One of our senior neurologists, the director for neurology intensive care, was the consultant on the service. And just quote from his clinical note, I believe that she had a transient ischemic attack. It's a pure motor event suggestive of small vessel disease. I cannot state with certainty, however, that this was not embolic, ... And then I've spoken to our cardiologist who feels that an MRI may be possible. Now remember, it's a recent implant and this is an ICD. Therefore, I've recommended that we go forward with an MRI to include diffusion-weighted imaging. So this patient has this classic issue of times when you specifically need an MRI. I think all of us understand the global issues in terms of like cost, radiation exposure being more with CT, but the key is specific diagnosis or specific clinical scenarios, growing number where it's very clear when you get that phone call that an MRI is really what the patient, the physician who's caring for that patient, malignancy, issues with the spinal cord, issues with soft tissue, issues with the brain really wants. And in this patient had an MRI done and clearly showed that there was evidence on diffusion-weighted imaging of multiple areas of ischemia or small infarctions, that this was a cardioembolic source. So can you do this? So can you do MRI safely in pacemakers in general, in conditional MRI, conditional pacemakers, ICDs, and in other situations? So if we think back and if we extrapolate these curves, they just keep getting more and more devices, more and more clear indications for an MRI. And remember, the growth in the devices is beyond pacemakers, ICDs, as well as devices with left ventricular leads, and an increasing number of patients where you have to make a decision on whether you'll extract existing leads or revising a system. So all of these are kind of like force it to come to a head. And we have in the back of our mind the two classic conflicts. On the one hand, we know in some situations get clear untoward effects with various aspects of the MRI. If we go back a few years, about 8 years, there was a clear FDA position with strong language, as clear as it gets, that if you want to try doing this, you have to have bench testing, specific device testing, specific field testing, the MRI in your lab that you're going to use, and do it all over again every time the device changes, or when the MRI in your hospital changes. So obviously, everyone sort of ignored this and published a series of observational studies, which was pretty much what we had to go by. On the other hand, there's difficulty in taking a blanket position to say, no, this is potentially unsafe, and therefore we're just not going to do it, because there are costs and health issues, including the possibility of death, when you have delayed diagnosis or you have patients may be prevented from having a therapy, especially the kind of patients that we put cardiac devices in. They're exactly the patients who have the likely need for specific diagnosis and early intervention if they're going to have a chance with their malignancy, neurological disorder, or in some cases, a cardiac disorder. So it's pretty much the issue that we have to deal with is all of these patients with devices and the number that you get even within a year of placing a devices with a consultation or call asking about an MRI. Now, what are the issues? Why is it a problem, and what are the differences with defibrillators and ICDs in terms of risk and between conditional devices? What's different in the conditional devices and what's changed as a result of their availability? Most of it has to do with the fact that there are three powerful fields when an MRI is being done. Just the magnets that the patient is exposed to, a static field, then the radiofrequency pulse that's used to create this electromagnetic scatter or radiation, and the dynamic or gradient field that is applied to get the scan and find issues. Now, the problems you get with the interactions are related to each of these effects. For example, if you look at the RF issue, that's something that can be picked up by the antenna of the lead, ICD, abandoned lead, or pacemaker lead, and produce heating at the tip. And this heating can affect the thresholds. It could conceivably, including reported early cases, cause a perforation of the lead from the heating itself. Now, even with non-conditional device leads, more recent leads tend to have fairly moderate in vivo animal study heating at the tissue, but still this is a major concern. Similarly, the dynamic field, the gradient field, or RF can produce stimulation through the lead itself, with or even without having a device hooked up to the system. Now, the main ones that we're interested in, however, the problem is device interactions can occur with all three of these situations, and you cannot turn off the static field. So this is a key issue, and the reason why there are strong feelings, controversy, and sometimes very strong opinions from radiologists saying they just scan in an MRI a patient with a cardiac device, regardless of the type of device you have. We also know that every one of these possible problems with devices have occurred, but most of these, including the one, of course, we are most concerned about, reported deaths, are from a long time ago. And there are many important differences between devices, even for the availability of conditional devices, of what we use now from, say, the 80s or maybe the early 90s. Yet, even with present devices, sometimes, although much, much less commonly, there is unpredictable device behavior. And this prompted really a call to say that we're doing this the wrong way. If we want to have safety with an MRI, with a device, then the device has to be developed from the ground up. It has to be developed to be MRI safe, rather than just retrospectively looking at it in patients who knows how they're selected, with things very difficult to control for, and relying on luck to make a complex and common decision. It's not only the issue of what can happen with the leads or heating, but it's also very difficult in terms of trying to scan out the spectrum of noise or filter out the possibility of noise when you have various types of EMI possible via an MRI and distinguish it from cardiac events. A couple of things about lead tip heating. We know that thresholds are lowest at implant, and If you have heating soon after an implant, then it's more complex because you have two concurrent issues that could significantly cause a change in threshold. And as I'll point out, the main parameter in studies to look at safety or compare conditional devices or scanning in patients with a traditional approach has involved looking at thresholds. So I think some of the things that we can look at and say is the threshold effects as such are not that significant as long as the threshold at the time of implant was good. We have to remember, however, that these nuances are difficult to understand when you have the person who's asking for the check to come in from being a non-cardiologist most of the time. So we need some simplified approaches along with collaboration with our radiologists. Our radiologists' main concerns are not only the safety of the patient, but the feeling that they just won't be able to give the information anyway. So the other side of the coin is issues with artifact, both cardiac as well as artifact that can occur fairly good distances away from where the cardiac leads have been placed. Testing with us for any new device and system has tended to follow the approach that was originally recommended and set up with Dr. Hayes some many years ago. But what really is what's changed for pacemakers specifically is the MRI conditional device. Now, most of you know we have one device available in the US, but the key changes I'll briefly review. In Europe, we have, there's options with devices from St. Jude Medical and Biotronic. Just a few issues to think about is even though these are MRI use devices, they are conditional, and the word is used specifically because it's still some specifications in terms of the type of scanner, the range of the scanner, and absorption characteristics limitations. Now, just a couple of things about recognizing the device for those of you who may not have implanted the devices and don't know whether the patient coming or you get the call on can have an MRI scan. You may know about pacemaker dependency already, but reviewing the X-ray to look for the proximal portion of the lead and very clear, this wavy line that you can see fluoroscopically, very easy to see, can help you recognize whether it is an MRI conditional device, even when you haven't seen the patient. Now, to emphasize what exactly this conditional means, remember that it has to do partly with patient characteristics and the type of MRI that's being done. Specifically, it shouldn't be centered on the heart with most devices. You should have this static field strength should be 1.5 Tesla or less. It should have some characteristics in terms of the absorption rate. So this is something that's programmable by the radiologist when doing the scan itself. For us, important things to remember is it shouldn't be implant less than 6 weeks, and should be good thresholds and normal impedance at the time in which the scan is being done. Now, these are there in a checklist which looks through to say that this information has been confirmed at the time of using these devices. So if we look at it, it's really a spectrum. You had some terrible results pre-1990, definitely pre-2000, where everything was stacked against what could happen with an MRI. And then we have other devices with questionable data, mostly retrospective, with a lot of caution in how they can be used and then the conditional devices. Similarly, terrible types of MRI, very big field strengths, non-programmable absorption rate, getting to be lower and lower risk. So two things getting together. What about briefly to look at ICDs in terms of data prospectively obtained? And to review this, the best data is from Dr. Nazarian's study. Both ICDs and pacemakers, non-conditional devices, they programmed asynchronous if dependent, otherwise kept it in a demand mode. All the patients were monitored with at least ACLS certified RN with a MD as backup. There were 3 patients where there was backup mode reversion. None of the issues related to transient changes in sensing or impedance required a revision or programming. So they concluded that it can be done safely in patients with selected devices and the appropriate backup. Few words about abandoned leads. Paul Friedman from our group looked at this in a few patients, both recent and older devices, non-conditional leads, and in this handful of patients, there was no effect noted. Similarly, ongoing data with left ventricular leads, non-conditional devices, similar protocol that I described previously, and so far, no issues thing. So this is kind of our approach that if an MRI is requested, mainly looking at how much review is needed, the type of the device that's there, and what options for scanning is available. Recently, Santini gave a simplified approach that kind of looked at the economics and some of the ethical and medical legal issues associated with picking who gets to choose what kind of device, and factored in age and life expectancy and whether or not they had a contraindication for an MRI to begin with. I'll just conclude by saying a couple of things that could change even from now how we look at MRI devices. So today, it's radiology, the type of scan. Cardiology, it's for us to recognize type of device, type of patient, and what kind of numbers we have. But with platform technologies becoming available, and where the leads themselves can be designed, not so much for MRI compatibility, but being placed epicardially, and with specific leads, it may not be possible. They're required for various reasons, perhaps for specific placement in the heart or stimulatory devices for heart failure, that you really can't make MRI conditional as far as we know now, that there still will be patients who have these type of leads, these type of devices, or ferromagnetic type of stents or shunts that may have specific purposes in the patient, that we still may need to fall back on safety or how to get safety data in a standardized fashion between centers, even when the device itself and the new leads that we place are conditional. I want to acknowledge, first of all, Dr. David Hayes, kind of a pioneer in this field of EMI and devices, still the same lab and setup that we use here. Paul Friedman for information from unpublished data for the non-conditional device studies, and for the generous use from Medtronic, St. Jude, Biotronic, and Boston Scientific of whatever non-proprietary information that they could share, and for me to use in this talk. Thank you very much for your attention.